So next up we have Dr. Manzi and Mainstay Medical. They're going to be showing off the Reactivate procedure. How you doing?
Hello.
Very nice to see you. Thanks for coming up to Idaho. It's actually beautiful. We haven't talked about that much.
It really is.
It is very beautiful. Coming from Florida with flat and palm trees everywhere, it has been very, very nice. So we're going to get started talking about a little bit Reactivate.
Thanks for having us. We're so happy to be here.
It's going to be great. So you want to go run the slides? Do you want to run the slides?
You can run it.
Yeah, you got it.
All right.
You get right.
Switch over here.
Grab some clothes.
All right. So happy to be here with Reactivate, talking about restorative neurostimulation for chronic mechanical low back pain. Chronic mechanical low back pain is, definitely something that we see every day in clinical practice. Patients don't really know what to do. They have all these different issues with their back, and we now have an FDA-approved system for chronic mechanical low back pain. The Reactivate device has been developed, indicated for bilateral stimulation of the L2 medial branch of the dorsal ramus, where it crosses the transverse process at L3. It's basically an aid in the management of that intractable chronic low back pain associated with multifidus muscle dysfunction. So this can be seen by imaging as well as physiologic testing in adults who have had failed therapy with pain meds as well as physical therapy and are not surgical candidates. Now, the issue with chronic low back pain is the loss of neuromuscular control. Reactivate has developed, it is a system that's developed to hopefully stop the neuromuscular instability problem. Again, diagnosed as chronic low back pain, being very nonspecific. So patients go to their primary care because they have this back pain that can happen over and over and over again every month, or usually it starts once or twice.
Every time they overdo it a little bit on the weekend.
Yeah.
Yep.
Or they just pick up a sock because they missed the laundry basket.
Yeah.
And you're just like, what in the world? My
There it
back.
is.
Oh, and then I'm going to go lay in bed for a day or two.
They're brushing their teeth,
Yeah.
they're emptying the dishwasher, everyday activities.
Every day. And then it just becomes more frequent.
Mm-hmm.
And you can see on the slide here, we have that downward spiral of destruction of the low back. So at first we have that injury. We have this instant inhibition, like, oh, let's protect our back, right? Our brain tells our spine, like, oh, don't move it, it's going to hurt more. And then it becomes an altered neuromuscular control issue. And ultimately, this leads to this instability and atrophy. And then patients become painful. Their back hurts, and they have this vicious cycle, and it repeats again a few months later, and then it repeats more often.
And the way I think of it is you lose that scaffolding of the spine, now all of a sudden disc, facet joints, everything's taking more of the pressure.
Exactly.
And that's where the pain's really coming from.
And, I mean, the interesting, as a physiatrist, you're a physiatrist, I'm a physiatrist, we're huge believers in bracing and spinal bracing. Your multifidi or your internal bracing system.
Stability.
And if you get rid of that, then you're putting more load on the joints and the discs, and then they fail. And that leads to these continuous issues that people have from a pain standpoint. So Reactivate and Mainstay Medical developed Reactivate basically to help this inhibition that happens. And we know from years ago, there's an arthrogenic inhibition with reflexes, especially in the quad muscle. There's pain and your quad gives out and you see these issues and continued pain in that area because of loss of neuromuscular control. You can see in the middle part here on the blue pictures, this modified motor control with cortical mapping. And the multifidi muscle is this deep muscle. But then you have the erector spinae muscles as well on the right. And you can see when the multifidi is disinhibited, the erector spinae, a bigger muscle group, has to take over. And so ultimately that leads to the disuse and atrophy and fatty replacement, as you can see on the MRI here. That white area surrounding the deep muscles, the multifidi, are replaced with fat. And you get this kind of marbling, non-filet mignon ribeye effect.
Yeah, I've always, that's what I say to my patients. I go, if you got served this steak, you'd send that back, right? We don't want to have that in your back.
Yeah, it's just too much fat, right?
Exactly.
We want a little more muscle in there.
Exactly.
So research has been being developed. Years and years ago, we didn't know what to do with this. Okay, yeah, you have fatty infiltration in your MRI. But now we've been learning.
Go to physical therapy, right? That's
Right,
always
go to physical therapy. Here, do your bird dogs.
There
Do
you
your
go.
bird dogs. Let's really strengthen that multifidi. But then, Russo in 2018, he started studying this, and there's new research now that we know, and it's very new. We didn't know what to do with this in the past.
No.
And now we know there is research behind it showing that it can be corrected.
And we can stabilize
stabilize
the spine. Instead of just trying to kill all the pain we have, we can actually try to get rid of it.
Correct.
Yeah.
So, Mainstay's got something here. It's
impressive.
It's
very
impressive.
I remember when I first heard about it, I'm like, if this works,
right, as a
this
physiatrist,
is it.
Right, as a physiatrist, I'm like, this is it.
We can actually fix the back. We don't
Yeah.
have to, cut it open. We don't have to put in rods and screws. We don't have to inject all day.
Right. So, because we're all used to doing palliative treatments, and this is
Yeah.
actually restorative, which is key. That's what we're looking for. Patients want to get better. Patients want to not just have destructive cutting type procedures or just filters.
Or,
This
exactly.
is-
Or even, stimulators are great, but
For sure.
stimulators for pain are just blocking the pain signal.
Yep.
This isn't blocking the pain signal. It's actually just activating those muscles to strengthen them.
Yep. Let's fix the problem, right?
Exactly.
All right. So here's some more research here. We know this is a 3-year study that Mainstay's published. And in 100 patients, we can see initially the first 4 months, we have the initial sham response, and then the patients receiving the treatment. At 4 months, we have a crossover showing that 3-month mark out all the way with long-term improvement in that VAS score. I mean, that's huge. Patients are getting better with this long-term.
And the reason I think they keep getting better long-term is, yes, you keep getting more and more stability, but these patients are off the couch. They're doing stuff. They're not afraid of their back. How much do we hear that all the time? Well, my back doesn't hurt. I'm like, all right, well, what are you doing? Well, I'm not doing anything because I'm afraid of it
I
hurting.
don't want to hurt it.
Yeah.
Because they know what's happened in the past when they did try to
Exactly.
pick that sock up. They have to be careful.
Yeah.
So, again, this is showing long-term improvement, which is huge. And now there's actually 4-year data out. We don't have that here today, but it's coming.
Mhm.
And it just keeps getting longer,
Better. It's
Improvement.
durable treatment. That's what we like to see in our field now. It's durable. We used to get really, really excited about 3-month, right? Epidural worked for 3 months.
No, for sure.
We did it. Now we're getting, some procedures out there like this that have 3 years, 4 years, 5 years.
Yep.
I think the only reason we only have 4-year data is that's how long we've looked.
That's how long
I'm
we've
pretty
looked.
sure when we get to
Right.
5 years, we don't expect it to get any worse.
And this study, they have patients out there 7 to 9 years now from the studies, and patients are
Still
better.
doing great.
They're doing great, exactly. So this is just an overview of the system and how we place it. The electrodes go over the L2 medial branches. I'll show you this in more detail on the cadaver we have here. We make a midline fascial insertion with the correct angle to get it to our desired target. And then you can see the tines on the lead are really cool. So the distal tines face one way and the more proximal tines face the other way because they're going to basically bracket that intertransversaring muscle between the transverse processes of each level to really hold it in place.
Yeah. And I love this because it means we don't need an anchor at the fascial level.
Hallelujah.
I love it. Not a big fan of anchors.
No, exactly.
And this has a self-anchoring system. It's very nice. Makes it much easier for the patient. Less midline incisional pain, too.
Yep.
Because there's no anchor there.
Exactly. And we make our little restraint loop with a pocket tucked over, and then we tunnel that through to the battery, the IPG, and it's a non-rechargeable system.
Mhm.
So, the patient doesn't have to worry about charging. It uses such low energy. Again, it'll last a long time.
Yep.
So, what is the patient selection? How do we know who's a great candidate for Reactivate? So, how do we assess lumbar multifidus dysfunction? Now, yes, we have back pain, but how do we know it's actually not firing properly? So there's different tests, and Mainstay's done a great job in, educating physicians about the proper testing and how to identify patients.
As physiatrists, physical exam, we love to hear it. Do a
let's-
physical exam. Do a good physical exam on all your patients out there.
Touch the patient.
Touch the patient. Do a good physical exam. We have to give a shout out to the guy in purple there
Man.
on the slide, Kyle Kiesel.
Amazing.
He is very good at teaching us how to do these physical exams properly. It really helps you diagnose.
And Kyle has trained many of the physical therapists that Mainstay has on board now. And all of Mainstay's training is so heavily emphasized with putting your hands on the patient, seeing what you can do to help them, and how to diagnose this. And so we have the multifidus toe touch test, we have a multifidus lift test, and a prone instability test. And in training, you'll learn how to specifically do these testing.
Yeah.
And it's very simple. But to do it properly, you know, the physical therapy team at Mainstay, kudos to them.
They teach us very well.
For sure.
They'll come into your office. They'll tell you how to do it. If you have physical therapists in their office, they'll help you out. They'll show your nurse practitioners, your PA.
Exactly.
Very important to get this so it can be pointing you in the right direction.
Exactly. But we also have the MRI findings.
Mm-hmm.
And so you can see at the bottom picture to the left, we have grade 0 multifidi infiltration, which is, you know, that's what we want. We want the filet mignon. And then as we go towards the right, we get that more ribeye.
Ribeye, and then even prime rib, I guess, at the end.
Exactly. So, you know, MRI findings are huge. So we need to look at our own MRIs, and we need to touch the patient.
Another reason to look at the MRI, I think, is, you know, make sure there's nothing surgical there.
Exactly.
Huge disc bulge, you know, some unstable joint. Extremely unstable joint, but
yeah, but most people do have a small, slight grade 1 or less spondy because they have the degenerative disc and they have the facet arthropathy.
Because you're not stable, so things are moving around.
Exactly.
Right? That's why you get the facet joint pain. You get the disc degeneration.
Yep. So those are all things you might also see on the MRI. Obviously, if the patient's surgical, the patient's surgical.
Mm-hmm.
We're not going to do this. But again, if a small spondy that's not unstable, hey, that's great. Degenerative disc, facet arthropathy, all these chronic achy low back conditions with weakness around the multifidi muscle. Let's strengthen it. Let's support the arthritic structures that are back there and make people feel better.
Great.
So let's treat the problem, not the symptoms. Again, it's the only FDA-approved restorative therapy for that multifidi dysfunction. And visit their websites. The website's amazing. Wealth of information.
If they want to get trained, they'll reach out to you guys.
Yeah, absolutely.
Reach out to
just reach out to your local rep, and we'll make sure that we can facilitate that for you.
All right, let's show it off. Let's do the procedure. This is my fun part.
All right.
Okay, so
we're going to line up the fluoro here at L3.
Okay, is that the picture we're at right now? Can you take another picture? We're going to come south by moving the table.
Let's just use that as a pointer. Let's do a picture again.
That's the newest one.
Okay. Where is my...
Let's get a little... Let's see the shot. 05.
L3
shot. Oh, we got a nice little scoliosis.
Yep.
5, 4, 3. Oh,
okay,
so one on the left we could take.
Oblique towards you a little bit, please. So the key is going to be lining up the L3 vertebral body.
There we go.
So I think we got a good picture right there. The L3 vertebral body needs to be squared off. So actually, I'm going to do this. I'm just going to take this to make it flat. Picture there. I want the end plate to be flat. Where am I want to line this up on the end plate because when I go lateral on a patient, especially with this scoliotic, this is a real patient, right? This is real world. It's not pristine. Look at all the osteophytic changes on there. But you can see here on the cadaver, it's angled. So when we go lateral, we need to make sure we're at this angle. So the wig is the wagged.
Yeah,
the wig is out.
I love using the wag. A lot of people don't use the wag. You have to line that up very nicely. When we go lateral, we'll show you that.
Exactly. So if we can line the fluoro up maybe a little bit, so we do have that when we go lateral, and then come back up. That way we know where we're at.
There we go. Shot.
That should do it.
There we go. Good.
Okay. Beautiful. So now the key is, depending on the patient body habitus, we need to make sure where our entry point is going to be. So usually I like to line that up over. Sure. We have the L4 spinous process here. This picture. Again. Okay, so just make a mark here. And then I'm also going to line up the guide needles. So let's point.
That's L3 spinous process. I think I moved you a little bit. Shot.
Oh, let's double check.
I faked you out. That's
faked me out. Okay.
That's L3 spinous.
That's L3. All right. Well, in that case, let's just do this. Let's mark the transverse process first. I'm going to come south here. So we're looking at this little guide needle. And the key is putting our guide needle down on the transverse process about a pedicle width outside. So that way we get to the superior edge of the L3 transverse process.
And this is just like a medial branch block.
Yeah,
right?
like a medial branch, like we're just lining it up.
Straight down,
Picture.
nothing too special.
Somebody bent my needle here.
Oh, I bent it earlier. Sorry.
It's okay.
You don't like bent needles?
No,
Oh,
sir.
wow.
I can make it do though.
To each their own.
I'm an expert here.
Flexibility.
I can figure it out. I can drive it.
I was trying to be a good tech for you and get you ready, and I'm
Bent the wrong way. Okay, there we go. Okay,
There you go.
so I have it on the superior edge of the transverse process, distal to the pedicle. Now, I'm actually going to move it off a little further lateral, just so I have enough room when I come in with my lead. There. Okay,
Nice.
I think that's way better. Now, we're going to do that on both sides, but I'm just going to stick to one side for now, just to demonstrate. Now, I need to figure out my entry point. So I want my entry point, again, to be depending on the depth of the patient. If the patient is larger, we're going to go more cranial because our depth has to be at a deeper dive, right? But if we're in a real thin patient, we can go a little further south towards the feet, so it's not as it's a little more shallow, so we can get the same angle. That's going to be key. I would say this patient's kind of in the middle.
Yeah.
So I would say, maybe right there.
Tip of L4 spinous process.
L4 spinous process. I don't want to go. My superior limit would be the inferior aspect of the L3 vertebral body, as the most proximal, or the most cranial I could go, and then I would say right here in the middle looks pretty good.
Okay.
So I'm gonna make my incision here. Thank you.
Trying to be a good scrub tech. It's tough.
Okay. Now, I would probably do it a good inch or so, because I want to make sure I get down to fascia, because I don't want that loop to have any strain on it. And it's going to be the long-term integrity of the system to make sure I'm not having any torque or pull later in life here. A little deeper there, cut down. And at this level, I'm going to pocket around here.
Nice.
Because that's where my restraint loop's going to go. It's going to go in this little pocket over here. And I put the pocket on the same side I'm going to put the IPG. And what I like to do is cut down first, and I make my IPG pocket as well. That way, bleeding's controlled, and then I can just do everything.
And then close it
And then it all gets closed up. It's very simple. All right, so I'm going to take my needle here. Take a picture there, see where we're at. And I'm going to go angle it towards my guide needle. The key is to put this needle inside the guide needle. So I'm hitting bone there, so I need to steepen up my angle a little bit. Still hitting bone. I'm actually going to come up a little further.
On your entry point?
Yeah, my entry point, because I'm just not at the right angle. Hitting bone is not cool.
Yeah, and it's interesting. People always ask us where the pitfalls in this procedure, where you can get yourself in trouble. We're not even going near the spinal cord. We're actually aiming away from it.
Exactly.
But if for some reason you were to get too deep here, you could maybe go through the interlaminar frame in there and get yourself in trouble. So just be mindful about where you are when you're hitting bone. Maybe think about it lateral. That was pretty cool.
Okay.
You just actually bumped the needles. Yeah, that was nice. That was
All
nice.
right, so I like my spot.
That looks really good.
I'm going to check a lateral.
Let's do it. Yeah. One image is no image, right?
Well,
We always say.
drive depth, drive depth, drive depth. Let's
Get that 3D.
Let's get our
picture.
3D picture in our brain, make sure we're going in the right way, right direction.
Let's see what we got here. Nice. Let me move you up a little bit. There you go.
Thank you. All right.
Very nice.
Okay. Come up a little further. And I'm going to put my guide
I
wire
can do
in.
some pointing over here for you.
Okay. That'd be great.
So you see the needle. You guys see my finger? Oh, okay.
There we go.
So see the needle coming in. We have this is L3 vertebral body. Just 'cause it's a little blurry, I'm just pointing out that it's L2 vertebral body, and this is perfect. You're in right at that L2 inferior border. Very impressive. She's coming in right through here.
Okay, I'm going to pop the guide wire through now. Felt it pop. The key is that the guide wire stays straight. And I'm aiming for that bottom corner of L2.
That's
The
beautiful.
yeah, so it's like, boom, right on the money there. Okay.
Great.
So I got my guide wire in, right where I want it. Make a little incision. I need to make a fascial entry point around my guide needle, because when I put the introducer in, it needs to go in and around.
I can show everyone what she's using on this side.
Okay, so my guide wire is in a good place where I want it. I'm going to take this guide needle out over my guide wire, and then I'm going to put in introducer where I made that fascial entry point over the guide wire to drive this guy down to my target location.
We were talking about this before. This is probably the most technical
This
part
is
of
the
this
most
too,
technical
right?
part. You want to grip at the deeper end, and you're pushing it in and driving it across that needle, or across the guide wire.
This is nice.
Here
You
it
can
goes.
see the guide
I
wire
did
here
it.
nicely.
Sliding nicely.
See the blocking needle.
The key is to not kink, and I think that the closer you grip, the more proximal you grip, easier it is to get it in.
Oh, it's very nice.
All right, it's going, it's going, it's going. Nice.
There's the sheath coming in.
Sheath is going there.
Nice.
A little further.
And how far are you taking the sheath?
About there.
About there. I like
Yeah.
that. Right there.
Right there. All right,
Perfect.
let's go back EP. Let's see what we have here. I like what I'm seeing so far.
I do too. Yeah.
So
You're making it look easy.
You want to give them a closer to that?
Oh yeah. I'll get it closer. I'll be Vanna White over there.
doing a great job,
Keep them away from
Anthony.
the rest of the
Just go over there. I don't know if we can. If we can.
You don't see it on the screen, but I do have the close up of it.
On that one too. Oh, I got you.
That's close up
Very
on,
nice.
on the tray.
Perfect.
That's close up on the
So I want my introducer needle to be a little bit past that guide needle, because when I put this tined lead in, I don't want the tines to be exposed. And I'm going to slowly retract the introducer back over the tines to deploy them. So what I'm going to do next, now that my introducer's in place, I'm going to take my guide wire out and I'm going to put the lead in. I'm going to unscrew the hub here. It just slides right out. Thank you. Now I'm going to put this in. Picture, just to make sure I don't come out. Okay, I'm really close. So the key is going to get that second lead right at the guide wire. Okay, so they're matched up. I'm now going to retract the introducer slowly, but just to the second lead, because I want to deploy the first set of tines. The two.
And this is where the two tines are.
Picture?
It's hard to see.
Okay,
Nice.
so I'm happy with that. So when I get to this point, I need to lock the tines around the intratransversary muscle. So what I'm going to do is give it a few little tugs. And I got a nice grip, maybe about 5 or 6 times. Now that I have that grip, make sure my stylet's all the way in, I'm going to further deploy the second set of tines. So this is the moment of truth.
Yes.
Keep it nice and still and pull back slowly.
Very nice.
Good.
Bueno.
Bueno.
That's good.
Muy
That's
bueno.
very good.
Okay. And then I'm going to get it past that last electrode. All right. I'm going to double check the lateral.
Yeah.
Just to be safe. Before I go any further. I really like to make sure AP lateral. AP lateral is checked because I want it in the right spot. I want the patient to have the therapy right where it needs to be.
Oh, that's perfect.
Wow, look at that.
Wow.
Yeah, very nice.
All right, textbook.
Very nice. So, for the sake of time,
Yep.
we usually go from here. You already made your pockets.
Yep.
Right?
Yep.
So,
What am I?
finish it off by telling them.
Okay, so I'm going to take out the sheath and the stylet. Removing both of those. Double check, nothing moved. Perfect. Love those tines. No anchors.
No anchors.
Okay, and then I did the same thing on the other side, right? So we have 2 of these. Now, pockets are made. We need to check. Are we in the right spot? We have to test it, right? So on the table, we're going to do twitch testing to make sure these multifidi are contracting. So we're going to hook this up with the rep here, and we're basically...
To the battery.
Yeah, and then we put, we hook it up to the battery. Once everything is, just to make sure we're in the right spot, we tunnel it over. We have a tunneling tool here, just like we do for SCS or other...
Same tunnel.
Same tunneling device to the pocket that we made. And the key with making the restrain loop is when we twist it around, we want to make sure it's in a pocket. It's in the pocket, but it's coming out the inferior end. So I'm going to tunnel it over here, but then when we tunnel it, it's going to come at the inferior end towards the battery. So come back AP and we can show them the loop.
Actually, let's go back to the slides. If we can pull the slides up.
Okay, perfect. That's a good idea. And come back AP. We'll get that AP view of the loop.
Because the slide, you can see the strain relief loop in the slide. Same side of the battery, down, around, and out.
Yep.
And it's hard to make it without making the pocket and everything. We don't have time to make the pocket and everything right now. But yeah, I think that was great. Very good.
So then make it a little prettier.
There you go.
One more picture. There.
Very nice.
And then it's out and looped and hooked to the battery right here.
Well, thank you very much. That was perfect. Textbook.
Thank you, sir.
Way to put it down. Thank you guys for being a part of this Mainstay as always.
It's always a pleasure.
And very exciting new procedure for chronic lower back pain. Like we said a million times when we first started, we're physiatrists. This fixes the problem. It doesn't just mask the problem. Pretty simple technique. If you haven't done this yet, reach out, see how you can get involved. This is something that should be right in our wheelhouse in pain management.
And if you're uncomfortable with suturing and pocketing, we'll teach you.
Yes.
It's very straightforward.
Yes.
So
you just got to get used to it. It's just something, once you do it, you'll be good at it.
Once you do it, it's fun.
Awesome, guys. Well, thank you very much.
Yeah, thank you. It's
Thank
always
you
a
for
pleasure.
having us.
Yes. I'll pull this out for you.